go.
All we've been
All
doing
right,
is changing
so
the
we're going to do an in-service on the IPV, intermittent percussive ventilator. As we mentioned a second ago, it is a ventilator. You could piggyback this onto your vent from breaths up to 300 breaths per minute, but you're going to primarily use it as a therapy.
Okay.
Your
Sounds good.
target objectives are
Yep,
going
no
to
problem.
be for alveolar recruitment, to increase flow rates within the lungs so that your patient can mobilize secretions a lot better. The short story of how it works is we're sending out those little micro tidal volumes, and those are eking in past obstruction or breaking down some obstruction as they get in. They're going to reach the distensible part of the lung and then kind of make a U-turn and come back out. And then as they come out, they're actually pulsing that mucus up and out of the lungs. So you don't have to put them in Trendelenburg to get the secretions out. You may need to help them with suctioning, or if they are able then to cough, and they're going to get that on them there. Right now, your target population is going to primarily be cystic fibrosis patients. I think that will probably evolve. Word on the street will get out that the machine is here and we can use it for other things. But right now, if you do get an order for it and it's not one of your CF kids, bring it to one of the Supes or Darcy's attention, and they will negotiate that with the medical director. So they aren't just order it out of the blue and get it done. If anything, if you guys have other patients in other populations and you see that they're not doing well with acapella, they're not doing well with PDNC, or they're not doing well with VEST, that would be maybe where this would come in and help them out a little bit. So, first thing that's important to know about is the circuit. And this particular circuit is the ventilator circuit, and I'm going to do that last. This is your regular circuit. It comes in a package that's going to look like this. And you have your nebulizer cup, you have a phasotron, and you have your harness or your tubing and a mouthpiece. I think you'll end up using the mouthpiece quite a bit because it's just much more comfortable to keep your mouth this way than it is to keep it round, which is how it would have to go onto the normal built-in mouthpiece of the phasotron. So in your circuit, as I mentioned, it's going to come together in the package pretty much built. It won't have the harness attached, but these things will come together like that. So you'll just open that up and then twist it so that it's positioned right so that the patient can hold on to the nebulizer and breathe the medication. Your medication cup, you're going to fill that with a minimum of about 15 cc's of liquid. So maybe an albuterol bullet and then a balance of a 15 cc just normal saline bullet. And then when you put them together, they line up, and then you give it a twist and it kind of locks it in and seals it. The other aspect of this is the phasotron, and this is the real brain behind the system. Dr. Bird invented this many years ago. But what it actually is, it's very simple. It just has a piston inside of a tube. And we're going to be adding gas intermittently into this end. It bounces in and through this diaphragm, which moves your piston back and forth. The farther it moves, the bigger the volume. The faster and smaller area that it moves, the smaller, the faster the volume. As it moves past this opening, which was where our nebulizer was attached, there's openings. It creates a venturi, so you're going to actually entrain the gas from your nebulizer. So that's the flow of the nebulizer would drive it this direction, but this is also pulling it into it. And then this port is just exhalation, essentially. The key take-home point on this little port is you don't want to stuff anything in it. It is the exhaust. It's got the aerosol that they're not breathing coming out of it. Sometimes it gets a little spurty, condensate. So you can add like a 6-inch piece of corrugated tubing here to divert it away from the patient's face. Otherwise, you don't want to plug it up because if you do, as I mentioned, it's kind of their exhalation port, and if they're breathing on this, particularly with this to a trach, they now have really no exhalation. Dr. Bird made this though so that people could mess it up a little bit. He did allow exhalation through here. There's just a little bit of a pressure to overcome with the rubber band pop-offs. On the back side, there's a one-way valve. Nothing too brilliant about that except that it's just keeping air coming in this way, not necessarily going out the back side. So that's your anatomy of your breathing circuit. And the last piece that was in that kit that I don't have it anymore is the mouthpiece that you can attach. You're going to attach the harness via color-coded fashion. So yellow tube goes to the yellow connection on the bottom for the nebulizer. And it just clicks, pretty much you just press it straight in and it'll snap. And then white is going to attach to the white end. And the last one, the red one, doesn't have a color to match it to, but it's the only one left, so it goes right here. And then if you follow it back to the machine, this kind of tells you what each of these do, but the red one, it says gauge. So it's right up here, proximal to your patient, so it's your proximal pressure gauge. This clear one is going to go to phasotron, so it's actually driving the gas into the phasotron. And the last one is aerosol, and it's your yellow. Just powering enough flow through there to make the nebulizer go. There's one last port on the front of this, and we used to have a disposable setup. You probably remember, parts, pieces, things to put together. They've eliminated that, partly because they can't get the durable plastic they were able to use. And now also just because it's a lot easier to have just the disposable kit and open that and use it. But this port is no longer used. If you want to stall or stop percussion, just for a brief amount of time, you can put your finger over that and it will stop it. But if you're doing therapy and you just want them to get aerosol and not get the percussion, there's other ways to manipulate it to make that happen. So we've got our setup. The next thing we're going to do is get our machine ready. We're going to plug it in to the wall. It hooks up to oxygen. So you're going to be delivering between 60 and 100% O2. If you have a patient that you need lower FiO2, you'll just need to get a cheater to plug it into the air. Mike would probably have those. Your settings on the front, you can just start them out so that this knob, it feels like it spins a lot, and it does, but it will stop. So you just want to turn it all the way to stop. And you can set the middle, the percussion knob. If you want, you can start it at wings up. That's always a nice, safe place. And by wings up, there's a little indicator on here that just looks like white wings kind of pointing up. And point those at 12. Or you're going to pretty fast move them over toward the left, which is the easy side. So you could start it over there too. I start it at about 10 o'clock. So if you're looking at a clock, it's pointing off to the left to 10 o'clock. The reason I don't start it completely easy is because if I start it at 10 o'clock and my patient's saying that, oh, this is kind of hard, can you make it easier or whatever, you have some flexibility to go easier and easier. So that way, it just gives you some room to fine tune it for them. And 10 o'clock is going to give you a pretty decent amount of rate. This is your on-off. This is your knob that allows you to easily see what pressure you're landing on. When it's percussing, it's hard to see because that manometer is vibrating. So you just press this and hold it. So I'm going to go ahead and flip this on. The first thing, even when I have this all the way off, I'm basically just a nebulizer treatment. I'm running flow through. And so this is how I would start my patients off, especially the first or second treatments. Let them practice. Let them just hold this. Let them inhale, breathe the aerosol mist, get used to kind of the contraption. And then, after they're comfortable with that, maybe a minute or two, then explain to them what we're going to do. We're going to add some percussion or some vibration to this therapy. And it's going to have similar outcome as when we beat on you or do percussive therapy, CPT, but it's going to be on the inside. So it's actually a little more efficient. It's going to help you move your secretions a little bit better. And also it's going to help us to inflate your lungs really nicely too. So when you're ready to do that, then you're gonna just take the operational pressure knob and turn that up. And you can watch it or you can just listen, because you're gonna hear it kind of stall out my flow, and like that. And then I'm gonna get to the point where I've actually got percussion happening. And my guess is that if I were to look, yep, I'm right about 15 to 20 on my operating pressure. If I want to see exactly what it is, I just press in this button, that holds it, and I'm actually at about 16. Okay? A good starting place, if you can get there, is to have it starting at about 20. So I'm right at 20 for my operational pressure right now. You're going to have them be breathing at this percussive rate where your wings are over here at about 10 o'clock. And you can chart, I think we're going to maybe chart whatever number is pointing to the name right here. So you chart that we started our high frequency fast rates with our number at 2. And you're going to try to encourage them to breathe on this for at least 2 minutes. As soon as I started my manometer, as soon as I have my patient on here, my manometer starts reading out a mean airway pressure and a rate. So you'll have that information to also document. So I do my 2 minutes or so on this level, and then I'm going to work it over. I'm going to turn the percussion knob over to about 10 o'clock. Slows it way down. It's moving that piston further, so the volumes are a little bigger. We're creating more flow, so we're kind of mimicking a clock.
Were we not at 10 o'clock already?
I'm sorry, it's at 2 o'clock.
Oh, okay.
We went from 10 until 2.
Okay.
Clarify that. So when we're at 2 o'clock, or over, if you look at this, it says hard on one side, it says easy on the other. We start easy and we move over to hard. So we're going to try to encourage them to do this for a minute or so, as long as they can. And at this point, they may be done, especially at their first treatment. They may just not be able to continue. And what you can do, because you're still going to have medicine in here, you can go ahead and just turn your operational pressure back down to just being an aerosol and finish off that way. As the therapist, your job is to encourage them, make them realize that this is going to help them in the long run, explain the benefits to them, and try to get them to go longer and longer each time. Typical therapy is going to be somewhere between 15 and 20 minutes. Any questions just about standard procedure?
So if they can go longer, is it in a hard position or easy or in between?
You can actually cycle. You can go like 2 minutes easy, 1 minute hard, go back to 2 minutes easy, 1 minute hard. You might find over time that they tend to tolerate, the hard better. What we have seen a lot of is that once they understand how to use it and they feel it, a cystic fibrosis patient might just manipulate this themselves. And they'll find the point where it does the best work for them. That's everything for this. You're ultimately working to try to get them up into the 30 to 40 range. And that's going to give you some pretty significant chest, and I'll just turn it up so you can hear you can hear that it's moving a lot harder. You can still do the fast side, but it's definitely going to be shaking their chest. You're looking for chest wiggle. And again, I can look and see where that's set just by holding this one permanently. And turn it off here. When you're finished, like you do with your regular aerosol therapy, you are going to rinse this cup out with sterile water. You can also take your hoses off of your Phasitron and you can rinse it out. Because if they have a lot of secretions, if they have a lot of secretions and they're puffing stuff up and it might get into here, you're going to need to get that out of there. You can actually unscrew the back side of the Phasitron, pull on the diaphragm and take that piston out and rinse it out underwater. I think that's probably a really good idea. Someone was telling me earlier about a patient last time, Cheryl, was saying that he took it out, he rinsed it, he soaked it in vinegar, set it all out, ready for the next treatment. And that's what they would do at home. That's how we would advise them. So since he had that going on, that was a really pretty awesome way to do things. You guys don't handle vinegar and you're not going to do all that stuff. So you're going to rinse it. And then we set it up on this stand so that it actually has another flow meter that's right over here that's ready to click onto this end. And you just put it on there and you can run this flow meter to dry it out. Okay. That is part A, or the part for using directly to trach. Usually people put in a little trach adapter, a little extension tubing and a trach adapter. Or you could put a piece of corrugated tubing in a face mask, like an ambu mask with soft cushion, and use that. Or lip mouth seal. You might, on your first treatments, you might carry a nose clip in your back pocket, just because sometimes when they're breathing on here, you know, they'll kind of clamp down and everything will just come out their nose and you won't be getting the right therapy. So use the nose clips and then you should be good. It's not like old IPPB, if you ever had to do that, where you had to practically sit on them to get a good seal. This will operate in the presence of leaks. It's just better to get it to the lung if there aren't any leaks. So, but you don't have to hold it on there like there's no tomorrow. So you're going to use this also with ventilated patients. Some patients you don't want to take off the ventilator. They're very precarious. They need their PEEP, they need their connections, they need their rate. Other patients you're doing spontaneous breathing trials, they're doing okay, they may not be ready to extubate. You could use this setup for that category. If they're lower than 8 of PEEP, lower than a rate of like 14, doing okay on spontaneous breathing trials, just take them off the vent, have it in standby, attach this to their trach or their ET tube, and do your 20 minutes of therapy. You don't necessarily have to work them up. You can just start them usually between 30 and 40. On your ventilator, in that scenario, you do need to give them pressure control instead of volume. Just because we're adding so much flow to the system, you will trigger all of your alarms constantly. So if you just move them over into pressure control for the duration of the treatment and put them back, if you're doing it in line. 90%, I would say, of the patients that are out there that are done on the ventilator, they just take them off the vent, put that one directly to it, do the treatment, and then put them back on the vent. Part 2. If you're going to use the ventilator, this is actually the circuit you'll pick up for that if you need to put it in line with the vent. Many of the parts are the same. You still have the phasotron, you still have the nebulizer, you still have the harness. We added a piece of corrugated tubing, of long corrugated tubing, so that you can actually have the nebulizer assembly hanging out back here, and then just this will be up by the patient. It just keeps, you know, one less thing from having to sit on their chest. When you get ready to put this on that patient population, I've done that twice now with the loop of my tubing. What you'll do is normally you have your patient Y, and you have your inspiratory limb, expiratory limb. When you use this, we're going to trade out their Y for a 3-way Y. I call it a tri. So you go from a Y to a tri. And that particular device is called a cone, IPV cone. And you'll just take your tubing off your Y.
Is that in the package?
Yes, and it's in your package, the big ventilator package. So then you slip your tubing over to here, put this back on your patient, keep them ventilating on the regular vent. Then you can get all of your nebulizer ready to go, and when you're ready, then your phasotron fits right into this one-way valve port. And you want to get it in there until it pops. And then you'll just be adding the therapy along with the regular ventilator rate. Does that make sense?
What will that do to an end tidal that's in line? Do we need to pull that out as well during the therapy?
Your end tidal, it's going to be seeing a lot of flow, so it'll probably wash out your CO2 a little bit more than you would have expected. You can leave it in and just know that it's going to blow it down, or you can take it out. There is another couple of little differences in the particular Phasitron for the vent circuit. One is it has a spring on its piston. If you are taking this out, cleaning it off, and that spring goes haywire and you lose it, it'll still work without it. So don't worry about getting a new circuit immediately. It's there to stabilize the piston, but the piston works just fine without it because the one that we use every day, we don't have a piston in. This is more kind of in the long-term world and where we really need something to keep that piston straight, and that helps do that. It also has a closed-off exhalation port because you're using your inspiratory and expiratory limb from your vent. You don't have to have a place to exhale. And the last thing that comes attached and ready to go on it is just an elbow that attaches to your aerosol therapy. So that's that. And then when you're finished with the treatment, you can leave this in line, but you can also pull it out and it'll just sit there and you'll still leave the cone in. It's a little more bulky than a typical Y, but it keeps you from having to break the circuit every time and having to disconnect and lose your PEEP every time. But there is a one-way valve inside here, so gas can go in, but it's not going to leak out. Yeah, did you try it on the bed? That therapy, it's going to be similar to your therapy on the general care floor. You're going to run them for about 20 minutes and then turn it off. We do recommend that you start your therapy, so you're going to go ahead and bring your pressure up and have your frequency over at 10 o'clock. Then you need to drop your endotracheal tube cuff down just a little bit. Reason being is that the reason we're doing this therapy is to loosen secretions and get stuff up and out. And so we tend to do a pretty dang good job of it. And if you get a big plug and it goes to the end of your ET tube, you're now plugged off and they don't have any place to exhale. So that's why we let the cuff down, so they've got a little bit of pathway around the cuff to exhale if need be. I know in my mind that throws up, well, VAB and stuff, we don't really want that cuff down. But when you have this running, you're putting in so much flow and then it's coming on out that anything that was sitting on top of that cuff, when you let it down, it's pretty much going to just go back to the back of their throat and it's not going anywhere down. Then, when you're finished, re-inflate the cuff, take everything off, and then you're finished. Okay?
So does taking the cuff down, doesn't make the ventilator go crazy?
Another reason to be in pressure control, because that's going to help. And you're not going to go down, you're just going to kind of go to a minimum leak, or at least a little bit of a leak, so that if they did cough, air can at least pop out, and you're going to know. I mean, you're going to be there and suction and do all that stuff, but just as a precaution.
The guy that we had on pressure control, it didn't, it affects the waveform so much, but it didn't cycle that. So that he stayed at his backup rate. But I was thinking maybe he'd get extra breaths because it would trigger or stay at the backup rate.
Were you in PRVC or pressure control?
Pressure.
Or just pressure, yeah. Because PRVC, which I think a lot of people use now, the volumes, it'll still alarm. So go to pressure control for the duration. And then
So when
remember to
they
turn
order
it.
this on a vented patient, are they also going to order their settings?
Until we get I would guess until we get an order set, we'll probably
Because they won't have a clue.
tell them what we want to do.
Yeah. This is how we have to do this. This is what you want. We're going to do this. Okay. We talked about starting settings. So you're kind of looking at maybe 15 to 20, especially for your little CF kids that aren't used to this. Start low and work up. On a vent, you can start up higher. Treatment education for the patient is probably key to getting them to succeed at the therapy. There aren't a lot of studies as far as outcomes, but the one big study that was published in the ARC a few years ago compared the VEST, the IPV, and doing PD&C. And pretty much what they established was that the outcome didn't change. It kind of depended on what worked best for each individual patient. And that's kind of where you guys are. You've got all the tools to be able to do the therapy that's going to work best for them. But the end is that if you've got a therapy that you can do in 20 minutes, what you used to take 45 minutes to do, that might be a good outcome and a good result. And that's really where this comes in, because you get full every lobe CPT done in 20 minutes.
So what are your recommendations on how to instruct them on doing it right?
Well, the first thing is if they are in band, especially young people, if they're in band, they were taught to play the clarinet or saxophone or whatever and hold their cheeks in and kind of pucker, but that's one of the big keys. They've got to learn to kind of tighten and hold in their cheeks. Second is it's going to be kind of ticklish, it's going to be kind of weird, it's going to feel very strange compared to what you're used to, but it's going to start, we're going to start out normal with the aerosol, and then we're going to move into that. And encourage them to give you feedback. It's like, this is too much, I need a break, this is not enough, it's not feeling like it's doing anything. Those are important things as far as educating them. And set their expectation. Like, our goal eventually is to maybe let this therapy work for about 15 minutes. We aren't gonna, you've got to work up to it. It's like running a marathon. You can't just do it today. You have to work up to it. Usually by the 4th or 5th treatment, they're probably up to where they need to be. And you're going to have actually a little algorithm protocol that gives you tips on where to start too in your policy. There are directions also on the front, and they talk a little bit, I think, about instructing the patient, but they talk about it.
Stop and cough. Do we stop the machine or just keep it going?
I would stop. I mean, knowing cystic fibrosis kids, when they stop to cough, it's not for a second, it's for a while. So I would just turn it off just because it's noisy, and you can easily turn it up back on. It'll come right back to what settings you had before. So I'd give them a break with that. But besides that, telling them that after you've had therapy and after you leave, it's important for you to let them know, expect to be coughing up more after I'm gone too. So we get it going, but we don't stay there all day for the rest of it to come out. And it's really important to educate your nurses with that too, especially if it's eventually, maybe it's a CP kid or CP person who can't really communicate but has to be suctioned. You need to make sure the nurse knows that you're in here doing this therapy that's going to get stuff really moving. They're going to have to be in there to suction. Our goal, get them out sooner, get them cleared out sooner, change their x-rays and improve their ventilation fast. And that's, you guys know how much a little kid can absorb of that, but that's the take-home point of what you're going to instruct them with. There's an x-ray over there, and it just shows they'd been doing EasyPap, and their x-ray was pretty much whited out on one side, and then after 6 treatments, they went to almost completely resolved nice x-ray. So it makes a big difference, and it's primarily that recruitment maneuver that you're doing when you're on the fast side, and then helping them get those secretions up and out.
So will this be used in lieu of a bronch?
It may ultimately reduce the number of bronchs that you have to do. There are some places that actually like to have an IPV treatment done before they do a bronch, just to kind of get stuff out of the way so they can actually get the bronch in and see better. So I won't say it will completely replace it, but I think that it will, I know that it will probably reduce your bronchs.
Your mini VAS?
Your mini BALs.
They'll still want to send it.
Secretions out. You do a mini BAL to get a diagnosis.
Yeah.
So don't ever let them order a mini BAL because they have secretions.
They'll order this and then a mini VAL behind it. Is what they'll do.
Yeah. As far as charting goes, I kind of mentioned it, but I would document the pressures that you've got your operational pressure up to. And when this displays mean airway pressure, kind of keep track of what that mean airway pressure was. And then duration, how the patient tolerated it, normal stuff that you would chart.
So the
But pass
final
on.
pressure or the starting pressure?
If I would go with what I started with and what we achieved. And I don't know how you're going to do all that in your computer charting system. Maybe you won't even put it all in there, but that'll be important information to tell the person that's taken over to pass on and report. Just so that they're not there starting over from 0 when they could start at 30 and have everything rocking and rolling right away. I think that's it. Things you might want to take with you, and some extra pieces of corrugated tubing so you can make that little thing to divert the exhaled gases. If you're going to work with a mask, it's nice to have a piece of tubing, corrugated tubing, just to give you some room, so you're not just holding that whole thing right in front of them. And if they have a trach, an extra piece so that you don't have all that stuff right here by your trach. That, I believe, is everything. Any other questions? Thank you.